Good day, students. And today's next lecture, wounds treatment. The behavior of round and flight. We are talking about external ballistics, and round is projectile. Is predictable enough that a skilled sniper can consistently hit targets at distances of over a kilometer. However, the behavior of rounds as they pass through tissue becomes idiosyncratic and extremely challenging to predict. Although still governed by Newtonian physics, wound ballistics describes a very complex set of interactions, and therefore there are few reliable rules or patterns to guide the clinician aside from gaining experience of these injuries. This part of the lecture will examine the specifics of these interactions between projectile and tissues rather than detailed techniques of surgical. Reduced to its fundamental form for the clinical context, wound ballistics concern the work done by the transfer of kinetic energy from the round, leading to crushing, lacerating, stretching, and shearing of the tissues. The kinetic energy transferred into tissues is simply the difference between the kinetic energy of the round as it strikes the body and that which remains should it exceed the tissues. If the round does not exceed the tissues, all of its kinetic energy will be transferred into the body. There are three specific mechanisms that will be addressed which allow this transfer of energy to occur. The shock wave preceding the round, the temporary cavity formed in the wake of the round, and finally the permanent cavity or wound tract left in the tissue. Shock wave. First factor is shock wave. This is an area of controversy within ballistic literature as the significance of this component is not fully understood. It has long been recognized that when a projectile strikes tissue, a tiny region of very high pressure is generated. This propagates through the tissue slightly faster than the speed of the sound in water, and therefore ahead of the projectile with a duration of 15 milliseconds, 25 milliseconds. Whether or not this subsequently has any significant clinical effect on tissues is disputed. Some investigators, particularly those examining actual shootings and animal models, believe a significant degree of this observed effect of gunshot wounds can be attributed to the shock wave. There is also a belief among some investigators that neural tissue might be particularly sensitive to the shock wave. However, others discount the wounding potential of the shock wave and regard it as insignificant or even non-existent when compared to the damage created by the temporary and permanent cavity. Temporary cavity. Temporary cavity is the stretching of the tissue radially away from the part of the round and occurs in its wake as it passes through tissue. When the projectile strikes the tissue, it is subjected to a significant increase in retardant forces from the increased drag and is decelerated. This deceleration involves the rapid transfer of kinetic energy from the round to the surrounding, causing those tissues to radially accelerate away from the path of the round. The process takes place over milliseconds as it must overcome the inertia of the tissues, hence occurs and continues after passage of the round. As the tissues accelerate away from the passage of the round, a temporary space or cavity at subatmospheric pressure is formed, creating a vacuum which potentially draws air and surface contaminants into the cavity via the entrance or exit wound. As the tissues are stretched, those tissues which stretch beyond their capacity to absorb such deformation will tear or fracture. Ultimately, once balance between the radial acceleration of the tissue and the energy the tissue absorbs as it's deformed is reached, the temporary cavity will cause its expansion and collapse back on itself. It will then expand again, albeit with less available energy. This is visible within models as an oscillating or pulsating wave of expansion and collapse which continues for milliseconds until all of the available transferred energy is completely dissipated, even when a projectile has left the body. The size of temporary cavity formed is proportional to the amount of energy delivered. It is important to recognize that cavitation does not occur equally throughout the wound tract. It will be larger wherever the contact surface area of the round is greater, allowing for that greater delivery of kinetic energy, such as is the round becomes unstable or fragments as described in greater detail. Permanent cavity. Round crushes, cuts, and shears tissue as it passes through the cavity, creating a tract that is typically of a similar size to that of the contact area of the projectile. The permanent cavity is typically a continuation of the trajectory of the projectiles, though it must be remembered that this trajectory can be deflected by tissue planes, bone strike, or otherwise from the instability of the round itself as it traverses the tissue. The entrance wound will usually be predictably minimal in size if the round strikes the body nose first, whereas the exit wound can be more variable. The large exit wound tends to only be present if significant temporary cavitation occurs at the point where the projectile leaves the body. If round fragments, which can occur either in soft tissue or after bone strikes, each fragment will subsequently continue passage to create a permanent cavity and possibly even generate a temporary cavity, if the fragment passes enough energy, dramatically increasing the volume of tissue damage in the wound. With regard to weapon systems and calibers of ammunition available, the number of variables make it difficult for a clinician to predict the injury pattern of the gunshot wounds as a casualty arrives. However, low-energy handgun projectiles traveling at low velocities typically only produce a minimal temporary cavity and may not exit the body. Gunshot wounds produced by these rounds usually involve damage limited to structures and organs lying in the path of the projectile. Therefore, through injuries where both entry and exit wounds, these structures damage can be predicted with a fair degree of accuracy where the path of the round is known. However, it's important to recognize that higher energy handgun rounds can sometimes form a more significant or clinically relevant temporary cavity, where the round has not been recovered or the weapon type is unknown. It is perilous to assume that damage from cavitation will not have been caused where the entrance and exit wounds appear minimal, as this can mask catastrophic internal tissue injury. It should also be remembered that, paradoxically, the higher energy round of a large caliber which passes through the tissues over a short distance may cause minimal damage, whereas in converse, the low energy round of a lower caliber which does not exceed the tissue will dump its entire energy load, causing potentially far more devastation to structures by comparison. Anatomic injury patterns. When considering the effect of gunshot wound It is important to differentiate the anatomic effect and the functional effect of the injury. High energy transfer wound to the thigh might involve a relatively large amount of tissue. But if no significant vessels are damaged and the femur is preserved from fracture, damage may be relatively minimal where, as previously mentioned, muscle tissue is able to tolerate significant deformity and stretch from temporary cavitation without significant injury. Conversely, far less anatomic disruption involving the central nervous system or the heart and blood vessels can be rapidly fatal. This is evident when one looks at the anatomic distribution of injuries in armed conflict. It's important to remember that military personnel are normally wearing body armor and therefore will sustain proportionally fewer injuries to their chest and head than unprotected civilian casualties. However, the small proportion of survivors with chest and head injuries relative to those with limb injuries gives some measure of the likely preponderance of extremity injury in a civilian mass shooting event. Tumbling and fragmentation. Military rounds are designed to resist drag. The effect of the tissue on the round increases drag. However, if the round tumbles or fragments, drag is dramatically increased and therefore so is the energy transfer. This explains why temporary cavities are at their greatest at the point in the wound tract where the round stumbles. Gyroscopically stable, high olive round will pass through tissue for some distance without significantly away from its central axis. Thus will likely exit the body with much of its kinetic energy retained. Conversely, an unstable, low expanding or fragmenting round will strike tissue with an increased contact surface area, allowing transfer of a proportionally large amount of energy. As the projectile passes through tissue, the torque or spin conferred upon it by the rifling is slowed, further reducing its stability and increasing the opportunity for away from the central axis. The drag coefficient is also increased, and the resultant rapid deceleration also leads to the round being subjected to bending and stressing, which can result in fragmentation of the round. Finally, it's worth remembering that many modern rifle rounds are designed such that the center of mass lies further towards the tail than the nose, so as stability is lost once it enters tissues. It can mean the round will reverse its orientation by 180 degrees or even 360 degrees during its forward passage, otherwise known as tumbling. If the penetration distance through tissue is sufficient, or if the projectile strikes tissue of high density such as bone, it is likely that the bullet will yaw significantly and may begin to tumble unpredictably, such as when its long axis is at 90 degrees to its trajectory as previously mentioned. The rate of energy transfer and cavitation is greatest due to the maximal surface area being in contact with tissues. When the round fragments, there is an overall increased surface area of the projectile in contact with these tissues. As such, the components are subject to considerably greater drag, so again there is greater energy transfer and tissue damage. If initial radiographs demonstrate round fragmentation, then it should be assumed that there is significant energy transfer and therefore significant soft tissue damage. Tissue density. While specific gravities of different tissues were examined earlier, it is now important to consider the clinical implications. The tissue that presents the greatest resistance to the passage of round is bone. If a round strikes bone, there is normally rapid slowing of the round and therefore energy transfer and tissue damage. A strike to a long bone shaft appears to result in a fracture with significant comminution. When low energy weapons such as handguns are used, there is a higher proportion of incomplete fracture seen. Whilst comminution occurs at a higher rate in high energy gunshot wounds, incomplete fracture can also be seen with high energy rounds and areas of bone that are more cancellous in nature appear to undergo drilling as the round passes through with little apparent damage away from the passage of the round, leaving a drill-out permanent wound tract. When considering tissue of less density, lung tissue is at the opposite end of the tissue density spectrum from bone and therefore occurs little tract runs as they pass through the lungs. Lung parenchyma is also an elastic tissue which can tolerate the stretch that occurs with the formation of a temporary cavity. However, if round strikes a rib as it either enters or exits the chest, there can be significant energy transfer as the round is destabilized, fragments or accelerate splinters of rib bone. Conclusion. This part of lecture has examined the mechanism by which a projectile transfers energy into the tissue following gunshot and the resultant effect in terms of wounds that are created. Mechanisms of wounding have been discussed with a particular focus on the creation of temporary and permanent cavities. The typical features of wounds with high energy transfer and therefore more severe wounds around fragmentation and bone strikes have been explained with clinical examples. Primary surgical maneuvers in the treatment of ballistic injuries are to save life and limb in accordance with the principles of damage control resuscitation. In subsequent procedures, the focus of surgical treatment shifts to preventing morbidity and to optimization or reconstruction. Surgical treatment of wounds should take place as soon as possible after wounding once life-threatening injuries and hemorrhage control have been addressed. Gunshot wounds are typically less contaminated than injuries caused by projectiles energized by explosive munitions. However, they are occasionally associated with considerable tissue destruction, which may be deep within the wound. Infection following open fractures caused by gunshot wounds and explosive weapons occurs in approximately 25% of cases and is associated with revision surgery and subsequent amputation. Prevention of infection is achieved by creating a clean vascularized wound bed by excising all non-viable or contaminated tissue and by reducing the number of viable microorganisms present by copious irrigation. The residual burden of contamination is thereby reduced to the level where the patient's immune system is able to suppress the development of infection. In this part, the term debridement is not used in order to avoid confusion. This term entered the English-speaking surgical lexicon after the Inter-Allied Surgical Conference of 1917, and in the 100 years since then it has been used interchangeable by mean either of both the act of incision and decompression and of the excision of necrotic or grossly contaminated tissue. For simplicity, this part will use the terms excision, incision, and decompression. All ballistic wounds, both gunshot wounds and those from explosive weapons, evolve over time. They should never be closed at the first surgical episode and may require recurrent surgical episodes for further assessment, tissue excision, and eventually closure or coverage. Time between surgical episodes is usually 2 days, so they can be safely delayed for 5 days in a patient not showing any signs of sepsis. The only exception to the rule of delayed closure head and neck wounds, which are typically more forgiving due to their vascularity. The majority of gunshot wounds affect the limbs in both the military and civilian setting. This chapter will focus on the prevention of infection in lymph wounds and will predominantly consider those injuries caused by firearms. Ballistic wounds and infection. The Jackson model of burns describes a wound in 3 zones. The utilized dead tissue is described as a zone of necrosis, while only slightly traumatized tissue is referred to as the zone of hyperemia. In between these extremes lies the zone of stasis, which can most usefully thought of as being vulnerable but viable tissue. This conceptual model provides a useful theoretical construct for understanding ballistic wounds and the rationale behind their treatment. Key to this is preserving the vulnerable but viable tissue by preventing further damage and necrosis. In practice, application of this principle is a dynamic process. The clinician must make a judgment on the status of the wound, the patient's comorbidities and resuscitative status, together with constraints of the environment and the chronicity of presentation. In the absence of other constraints, the excision of tissues that may have large functional impact should be subject to a more expectant approach. Examples of where this may be appropriate would be injuries to major nerves, those involving structures of the head and neck, and in cases of urogenital injury. Wound incision and compartment decompression. The passage of bullets and fragments through muscular compartments imparts energy into those tissues. Muscle tissue can survive that stretching effect of the temporary cavity but will be left inflamed, leading to swelling and the generation of exudate. Whether or not this occurs with significant hemorrhage, there is great potential for compartment syndrome to develop. In the presence of features associated with high energy transfer, prophylactic full fasciotomy should be considered. This approach is particularly important in an holster or mass casualty setting where the ability to monitor a patient and rapidly return to surgery is limited. Obviously, clinical symptoms of compartment syndrome mandate from formal fasciotomies following ballistic trauma as it would with any other injury mechanism. Wounds should be extended longitudinally along the limb. The incision should be sited to permit formal fasciotomies and avoid perforating vessels that may be required for future reconstruction. Longitudinal incisions across flexor creases should be avoided in favor of oblique or curved incisions. Even in cases where full fasciotomies are not judged necessary, local decompression of fascia to well outside the zone of injury is a safe strategy which will permit post-operative swelling as well as aiding drainage. The benefits of wound incision should not be negated by tightly packing the wound or application of restrictive circumferential bandage. Wound excision. The aim of wound excision is to convert a necrotic and contaminated wound to a clean and healthy one. Necrotic tissue is a potential site for microbial organisms to colonize as it provides a source of nutrients and is isolated from the patient's immune system. The accepted treatment strategy is to remove this potential site of colonization by surgically excising all necrotic tissue. Skin is an elastic tissue that tolerates the stretch of temporary cavitation well. In the words of Sir Gleaf, one lesson that must be relearned in every war is that skin is very viable and very irreplaceable, and as little of it as possible should be removed. The common pitfall for those not familiar with excising ballistic wounds is to start from within the wound, enlarging it until all the contaminated tissue has been removed. This approach risks both inadequate tissue excision and inadvertent damage to neurovascular structures. A preferable approach is to ensure that the wound is extending to outside of the zone of injury. If neurovascular structures are suspected to cross the zone of injury, then they should be identified in injured tissue and traced along their path. This approach also permits easier identification of the wound zones described above, facilitating decision making regarding non-viable tissue. High energy versus low energy gunshot wounds. In order to identify and excise all necrotic tissue in a gunshot wounds, exposure or lying open the entire wound tract won't be necessary. This could potentially require the transection of otherwise uninjured muscle compartments and result in greater functional damage than the original injury. Despite this concern, this aggressive surgical strategy has previously been advocated in military gunshot wounds. It's now recognized that in a low-energy wound there may only be a small amount of necrotic tissue of a quantity manageable by the patient's immune system. Surgeons with experience of gunshot wounds from the pre-antibiotic era in the First World War regarded to laying open of through and through wounds as a cardinal sin, since they healed up well without invasive surgery and few this involved. After the majority conflicts of Korea and Vietnam, military surgeons used animal models to confirm their clinical experience that simple through and through wounds of the limbs can be managed with wound lavage, local fascial decompression, and delayed closure or secondary healing. Civilian surgeons working in an environment where they can be confident of the low energy nature of the injury, for example, due to the use of handguns and with adequate resources to enable early access to the operating theater if required, have even advocated non-operative treatment of these wounds. The safety of this approach is supported by randomized controlled trials, which demonstrate no greater rate of infection in gunshot wounds from handguns treated operatively versus non-operatively. However, when the weapon and circumstances are unknown, it is important to treat the wound and not the weapon. Coupland suggests that the gunshot wounds with a skin wound greater than the diameter of 2 fingers involved significant energy transfer suggestive of cavitation, and therefore the wound tract should be fully exploded and laid open. This strategy was based on the hospital experience of the International Committee of the Red Cross when dealing with injuries that were often presenting after a delay of several days without antibiotic treatment. In a similar setting and with delayed presentation, a more aggressive approach may be mandated. A more aggressive approach is also appropriate if they are uncertain about if repeat surgical treatments may be possible. However, rather than relying on absolute rules, a more nuanced approach to gunshot wounds is possible. In the recent experience of management of gunshot wounds from high-energy military weapons in Afghanistan, it has been possible to stratify wounds according to the amount of energy transferred from the projectiles into the tissues. Greater energy transfers occurs with bone strike, bullet fragmentation, or bullet retention. These factors can all be determined at time of initial assessment by radiological and clinical examination. High energy transfer wounds require thorough and careful assessment of the whole wound tract for potential deep pockets of necrotic tissue. If a gunshot wound lacks and features of high energy transfer, surgeon can consider minimal debridement of visible wounds, local release of fascia, and fluid lavage. This can possibly be augmented by flows in the tract with saline-soaked ribbon gauze introduced by the passage of the Olympus clamp along the wound tract. This conservative treatment of low-energy transfer wounds can only be safely carried out in specific circumstances. The initial surgical exploration should be done within 24 hours from point of wounding in a patient who has had early administration of systemic antibiotics and when circumstances easily permit return to surgery should signs of local or systemic infection develop. If these conditions are not met, a more aggressive surgical exploration is likely to be a safer strategy. Cases of delayed reconstruction may be expected in mass casualty terrorist firearms attack either due to local facilities being overwhelmed or prolonged transfer timelines to supporting hospitals. This is especially pertinent in the case of limb injuries requiring reconstruction, as they are likely not life-threatening and may therefore be triaged into lower categories. In this situation, the presence of bacterial biofilms covering wound surface is a key concept in management of infection. Authors have coined the term tumor-like excision in orthoplastic practice and suggest practical techniques including staining the wound cavity with blue ink and excising all the stained tissue or stapling a gauze part into the wound and excising the tissue with the gauze in the continuity. Wound irrigation. At the start of the First World War, gunshot wounds were irrigated with a variety of antiseptic solutions. Sir Alexander Fleming was working as lieutenant in the British Field Hospital in Belgium and recognized that the hundreds of ballistic wounds being treated with various irrigation solutions were a grim natural experiment. He took numerous samples of wound tissue from injured soldiers and demonstrated that there was increased bacterial loads in wounds that had been treated with antiseptics. He described this counterintuitive observation to the toxicity of chemical antiseptic to the host tissue. It also makes it necessary in the estimation of the value of an antiseptic to study its effect on the tissue more than its effect on the bacteria. In terms of the Jackson wound model, this effect is the chemical damage of antiseptics on the vulnerable but viable traumatized tissue, tipping the balance towards necrosis. This effect has been demonstrated in animal models of traumatic wounds. Since Fleming's work in the First World War, there have been no clinical or preclinical studies that have demonstrated superior efficacy of antiseptic chemicals over saline. The recent flow study in 2015 confirmed the superiority of wound irrigation with low-pressure saline. In summary, minimizing infection in gunshot wounds is achieved by physically removing contaminants and wound exudate. This is best done by irrigating the wound with large amounts of normal saline diluted at low pressure. Antibiotics. Ballistic wounds are always contaminated. In fragmentation injuries, this contamination can be massive. The administration of systematic antibiotics is a priority. Early administration of systemic antibiotics, even in the pre-hospital context, can allow surgical treatment of wounds to be more safely delayed, an important consideration in a mass casualty situation or in an austere environment. The application of local antibiotics after wound incision and excision enables a higher concentration of antibiotic to be achieved in the wound whilst avoiding systemic toxicity. Presently, there is no ideal vehicle for the administration of local antibiotics, but the use of antibiotic-impregnated polymethyl methacrylate beads to create a high local concentration of antibiotics is well accepted. The choice of antibiotics will be guided by local policy and the circumstances of wounding. For example, wounds sustained in an aquatic environment may require gram-negative cover, and those potentially contaminated by feces or sewage may need anaerobic cover. It's important not to regard ballistic injuries as exotic or inherently different from other injuries. Even in wounds sustained on the battlefield, Staphylococcus aureus is the most common causative agent of wound infection. Dressings. Once wounds have been rendered clean and healthy, dressing need to be applied. The primary aim of dressings is to prevent secondary contamination and allow exudate to safely drain from the wound. For the same reason that antiseptic solution should not be used to irrigate wounds, antiseptic soaked wound packs should never be applied to traumatized tissue. Loosely packed gauze, either dry or soaked in saline or impregnated with petroleum jelly and secured with wool and crepe bandages, is a safe and low-cost dressing. However, in large wounds, these dressings can rapidly become saturated with exudate, causing an unpleasant odor for the patient and a site for bacterial colonization. The use of nanocrystalline silver dressings has not been shown to be more effective than plain gauze dressings in a randomized controlled trial performed on patients with ballistic wounds. Topical negative pressure dressings, also referred to by their proprietary names, vacuum-assisted closure, provide an alternative dressing for ballistic wounds once they have been adequately treated surgically. These dressings satisfy the aims of ballistic wound dressings by effectively sealing the wound from outside contamination while simultaneously removing exudate as it is discharged. They have the added advantage of being able to keep patients clean and comfortable in cases of very large wounds bilateral limb amputation. It's important to state that topical negative pressure dressings do not negate the need for adequate surgical treatment of wounds as soon as possible after wounding. In the absence of clinical signs of sepsis, topical negative pressure dressings can safely be left over an adequately debridement wound for up to a week. All limbs traumatized by ballistic wounds should be splinted even in the absence of a fracture. In those limbs with an underlying fracture, splints should be used to rest the tissues which are susceptible to infection if used excessively. Conclusion. Prevention of infection is a priority for managing a ballistic casualty as soon as life and limb-threatening injuries are addressed. Administration of systemic antibiotics and the surgical treatment of ballistic wounds should take place as soon as possible after injury. It's possible to judge the likely amount of energy transfer into the wound by use of clinical and radiograph evaluation. Surgical treatment should be tailored according to energy transfer. Wounds sustained through high energy transfer require more aggressive tissue excision. Low pressure saline irrigation should follow adequate wound incision and excision. Ballistic wounds should never be closed at the first surgical episode, with the possible exception of head and neck injuries. Topical negative pressure dressings are an ideal choice for curing wounds in between surgical episodes. Thank you for your attention.